So next we have a fantastic title. I'm really keen to know what the answer to this is. Why should the NHS make cardiac CT a priority? And we have Dr. Ausami Abbas, who is going to be speaking to us. Highly published consultant cardiothoracic radiologist. I've been having a little Google. So really impressive. And clinical lead cardiothoracic radiologist in the University Hospital of Southampton, and many other strings to his bow. But thank you. Take it away.
Yeah, no, so thank you very much. So I'm going to talk to you today by why I think and why we should all think the NHS should make cardiac CT a priority. Just some declarations. I just want to say thank you to Bayer for supporting this talk and giving me the opportunity to share my passion for cardiac imaging with you today. My passion exists because I think cardiac imaging can have an impact on the lives of many people in the UK and can change the course of people's lives when it's applied correctly. So thank you very much. I'm also the accreditation lead for cardiac imaging for the British Society of Cardiovascular Imaging in the UK, and so that is a conflict of interest when I'm asking people for money for cardiac imaging, so I put it in there. So the topics I'm going to touch on today are mainly why cardiac CT is so important to UK health, and I'm going to focus primarily on that. I'm also going to talk about what the current capacity issue are with cardiac CT in the UK at the moment, and then finally I'm going to touch on if we fund cardiac CT, how can we get the most return on that money we put into the system, because there isn't a bottomless pit, and I think money that goes into the system in UK health has to be returned at least equal, or at the very least, and ideally make a profit, so that that money can get reinvested into parts of healthcare that are less appreciated. And I hope I can make that case for you today. So why is cardiac CT so important? So if we touch on cardiovascular health in the UK, so a quarter of all deaths are cardiovascular disease related in the UK. There's one death every 3 minutes from cardiovascular disease and one hospital admission every 5 minutes. So if I stick to time, that means by the end of this talk, from the start to the end, 4 people have been admitted to hospital with a heart attack, and sadly 7 people will have died just from the start to the finish of my talk. And when you think in those terms, that's quite stark. There are 30,000 out-of-hospital cardiac arrests a year, and the health economic cost of cardiovascular disease to the UK alone is more than 9 billion. And I don't think that fully takes in the loss of workforce and the loss of productivity that arises as a result of cardiovascular disease in the UK. And this picture is mirrored across the whole of Western Europe and is starting to be mirrored across less developed parts of the world. So cardiovascular disease is a real problem for the world, and it's becoming more of a problem. So just to familiarise as to what the current kind of UK practice is, if you have chest pain and stable chest pain, which essentially means you're not having a heart attack, you're having ongoing pain that needs some form of investigation. Typically, those patients will interact with primary care, sometimes with the emergency department. They'll get referred on to a rapid access chest pain clinic, which is run by cardiology services. Those patients will either get no further test and be discharged with non-cardiovasculated pain. About a fifth to a third of patients, depending on the region, will have no further test. And then the remaining patients will have investigations, typically CT, MRI, echo, or direct angiography, although direct angiography is increasingly out of vogue in this situation. And then having had that test, they'll go back to the cardiologist, be re-seen in clinic, and then they may go on to have another investigation. So if they've had a CT, they may go on to have an MR. If they've had an echo, they may go on to have a CT. So quite big pauses and waits in this system already. And then if they haven't had their definitive treatment, they'll then go on to have their definitive treatment. And the nice guidance in 2016 was that 90% of patients who present to this pathway should ideally be offered CT as the first line test. And that is something that isn't happening in the UK at the moment. So what are the types of investigations? So let's see if this pointer works. Yep. So this is a catheter angiogram, and you'll show this has shown really nicely a stenosis in the coronary artery, so a narrowing of the vessel. This is an invasive test done by putting a catheter into the person's artery in the wrist or into the groin, passing a catheter up into the heart to the aortic root, and injecting contrast directly into the coronary arteries. So it's invasive, it can have complications, It's a day case procedure, and it has complications as well. Something like a 1 in 1,000 risk of death, which is quite a lot for an invasive test when you have other options. So typically this has gone out of vogue. Last 10 years, very few people go for direct angiography from chest pain clinic. Secondly, you have things such as a stress MI, so perfusion imaging. It can be a nuke test, it can be an MRI test. And essentially, this is someone who, at stress, we're giving them a drug called adenosine, and at rest, they are at rest. We're not giving them anything extra. We're increasing the blood flow to the myocardium and trying to show areas where there is reduced blood flow. You can see here there's some reduced blood flow here, indicating that there's a narrowing to that part of the myocardium, indicating there's ischemia. And then finally, we can do coronary CT, which beautifully shows plaque. And you can see here, this is areas of plaque which is calcified, but actually we can see plaque that isn't calcified. And so CT, I think, was a really good test for plaque. The stress imaging is really good for ischemia, and catheter angiography is really good for stenosis. Just be aware that CT is also pretty good for stenosis. It's not quite as good as catheter angiography because it doesn't have the same spatial resolution, but it's a very good test for luminal narrowing, and so that's why catheter angiography is now out of vogue. So what is the impact of applying CT on chest pain outcomes? So the Hart trial was a trial performed in Scotland where patients presented to Rapid Access Chest Pain Clinic, and they were stratified into two different treatment arms. One arm had CT as part of the investigation process, and then standard of care or routine practice of care at the time. And then the other arm had routine practice of care, but without CT. And then they followed these patients up for 5 years. They're still following them up, but they published the 5-year data. And essentially what they showed was that basically at 5 years, if you do a CT for any patient that turns up to chest pain clinic, the number of patients that go on to die in that clinic is halved, which is amazing. Almost unheard of in an imaging intervention arm. And then similarly, the number of non-fatal MIs will also be halved. And so I think this graph is the human impact of doing CT. Can you stop people dying? Can you prevent people from being bereaved? Can you keep families together? So I think there's the positive in that sense. And then I think if you're cold-hearted and you like Excel spreadsheets and you're really worried about the ins and outs in terms of finances, which of course none of us are, but this is a really important graph because this group of patients who don't die from heart attacks, are a real resource-hungry group. They go on to have ambulance, so the ambulance takes them to hospital, they go through A&E or CCU, they spend time on a monitored bed, they might go to ITU, they may have cardiac surgery, a lot of them will go on to have stents inserted, they will have ongoing cardiac rehabilitation, and they'll have ongoing outpatient cardiac care. So this is a group that uses a lot of resources if just taken to account. And so you may say, well, that's a trial, and does that really get reflected in the day-to-day running of the world? So some of my colleagues in the British Society of Cardiac Imaging pulled the real-world data from the UK, from NHS England, looking at what was the real impact over the last 10 years of doing more CT in actual fact in the NHS. Slightly complicated graph, but basically I'll explain on this one. So this is all-cause death. So this 0 is essentially change in mortality, and this the y-axis is the increased rates of doing CT, so coronary CT. And basically what these graphs are showing, that if you do more coronary CT, fewer people die. This is the rate of change of death. So in a real-world setting, fewer people die if you do more coronary CT. And that is replicated if you break it down into cardiovascular disease, if you break it down into cerebrovascular disease, so strokes, and then specifically coronary artery disease. So real-world data matches that quite stunning Hart trial data. So this is happening day-to-day in our NHS for the last 10 years. As part of this study, they looked at something which I thought was really beautiful, and I think it really hammers the point home. So the green map of England is basically a map of increasing cardiac CT usage over the last 7 or 8 years, and the blue map of England is the change in cardiovascular death. And essentially, the darker bits of green are the areas where the amount of CT we perform has increased the most. And on the blue map, the areas that are darker blue are the positive benefits and reductions of cardiovascular deaths in those regions. And I think the stunning thing is if you take different parts of the country, they virtually match up So the more CT you do on your doorstep, the fewer deaths you have on your doorstep. So if you fund cardiac CT in your region, in your borough, in your hospital, those benefits will be seen in your local area. So I think that's a really powerful message. So why is CT so impactful in stable chest pain pathways and outcomes? It's because, we don't know for certain, to be fair, we don't know for certain, but we believe it's because we can see plaque on the CT, and all the other tests that I showed you, they show the surrogate endpoints of plaque. So they show you the luminal narrowing, they show you this reduced blood flow to the muscle, there are other tests that show you reduced muscle contractility. But if you don't have those things, you can still have plaque, and those tests will be normal. And so there are patients who have plaque who have a normal test on those other tests who don't get the opportunity to be treated. Whereas if you do a cardiac CT, there may be no luminal narrowing, as there isn't here. There may be no downstream impacts on the muscle, which there isn't in this person, but you can still see the plaque. And so that gives us, the clinicians, the opportunity to change this patient's future outcome. We can do that by giving optical medical therapy, which typically includes statin therapy to reduce cholesterol, but also changes in lifestyle, so they can stop smoking, they can exercise more, they can eat better. And the other powerful thing about CT is we know if we show the patient their CT and we show them plaque, they are much more likely to adhere to the medical therapy, and they are much more likely to go on and persist with their lifestyle changes 3, 4, 5 years down the line. So not only does it give us the opportunity to treat patients who we wouldn't have known needed treatment, it also improves their adherence to that treatment. And we think that is why we are seeing such stark differences in the research trials we've done and in the real world data. Okay, so what is the cardiac CT provision and capacity in the UK? So in 2016, we looked at two things here, really. So on this map here, this is the number of CT scanners that were able to do cardiac CT per 100,000 of population divided by region. And on this side, this was essentially the number of accredited cardiac CT practitioners, i.e. the people that can supervise and report these scans, again divided by regions. And we colloquially called these traffic light maps, essentially red being bad, where we needed to do better, amber being okay, but needing improvement, and green being go, 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 you're doing really well. And you can see back in 2016, there was very little green and there was lots of red. So we needed more scanners and we needed more people who could supervise the scans and read the scans. Now, we have made a significant improvement in this, but in the Cardiology Get It Right First Time review, they made specific point of saying that there was significant regional variation in the investigation of stable chest pain, and that those variations were largely driven by difficulties accessing CTs within that pathway. And both this report and also the Royal College of Radiology report on the same topic have highlighted some barriers to doing better in this area. One of which is there remain 10 to 15% of radiographer posts that are unfilled, and without the people that can support the scans and perform the scans at the scanner, it's very difficult to expand numbers. There's a pressing need to increase the number of people who are trained to supervise and report the scans, although lots is being done to bring this into core curriculum training for both radiologists and cardiologists, and hence why there's been some improvements. And the reality of it in the UK is we don't have enough CT scanners for the imaging we need, and that means we're on the back foot compared to the rest of Europe and areas of North America, because we just don't have the scanners to do the scanning. Now, lots has improved because the scanners have got better, and so more scanners are cardiac able or cardiac ready to do the scans. And we have done better with workforce planning, despite the obvious challenges that we all know of in workforce planning that's happened in the last 5 years, pensions, morale, junior doctor training, etc. But we have done better, but we need to do more. So what do we need to do to get more numbers through? Well, we need more CT scanners and we need better infrastructure. I personally think cardiac CT is best done in hospitals, but certainly diagnostic hubs can be adapted to do cardiac CT with the right staff and the right support. And then we still need to do more with the workforce. We need to train more people. We need to retain people better. And I think we need to create an environment where people want to stay in the NHS and they want to stay in UK healthcare, because if the process continues the way it's going, all we're going to do is train people to work in Australia, New Zealand, Canada, and elsewhere, and we need to try and make things better from that perspective. But we have made progress in the last 7 years, and we're much better placed to deliver cardiac CT than we were in 2016. So finally, if we put money into cardiac CT, how can we get some return on that? How can we optimize that investment? Because everybody wants this funding, everything needs this funding, and so this is how I think we can use that money wisely, such that actually by funding this in the short term, you can fund other things in the longer term. And I would divide this up into passive, pragmatic, and innovative approaches. So let's start with passive approaches. So the really good news is, if we put the money into cardiac CT, you actually don't have to do anything other than deliver those cardiac CTs to get massive returns on that funding. So we don't have to do anything clever, we don't have to do anything innovative, we just need to put the money into the service. And we know that because of all the things I've shown you before, that if we have fewer non-fatal myocardial infarcts, if we have fewer strokes, that's going to have a significant impact on where downstream over the next 2 to 10 years, those patients then interact with our healthcare services. So you'll have fewer hospital admissions, there'll be fewer patients returning to A&E over the next 10 years. The use of ITU, CCU, and acute stroke beds can be placed to other people because these patients won't present. Half of these patients won't present anymore. Reduced primary intervention for coronary disease, reduced stroke thrombolectomy, less burden for the ambulances, etc. And then ongoing reduction of cardiac rehab, outpatient services. So just by reducing the number of non-fatal cardiac MIs and strokes, we can have a massive effect just by doing a CT. And you don't have to do anything innovative. You just have to put the money in, and you just have to put the structure in. Easy for me to say, I know. Pragmatic things that we can use to also make a difference. So you can see this traffic light map showing the number of accredited cardiac practitioners, and a lot of it being red. So at the moment, cardiac CT in the UK largely is supervised by a consultant or a trainee who is within a year or two of becoming a consultant, so very senior clinicians, and they generally, for every hour they spend reporting a cardiac CT, they'll spend an hour supervising the scan, which halves your reporting capacity essentially. I think we should be promoting advanced practice radiographers who take ownership of the scanning, take ownership of optimizing the images at the scanner point, and that would potentially free up some of our already existing cardiac and radiology reporters to then report the scans. And you could conceivably, I don't think it's ever as big as this, you could conceivably double your reporting capacity if you were able to remove the current reporters from the supervision of the service. And this is happening in a number of hospitals in the UK at the moment. It happens in Plymouth, it happens in Portsmouth, it happens in Blackpool, but this probably should be the standard of care, not the outlier. And that would be an easy way to, I think, massively expand the capacity of reporting without having to get new consultants, new trainees. And as a pragmatic way of doing better, I think this will be good. And then an innovative way. There's many different innovative ways we could use the money. I think certainly we could all incorporate AI into the reporting pathway, use it to identify which patients have bad disease versus low disease, so you can prioritise those reports. But I think one thing we should look at is fundamentally how we do chest pain in this country. So you saw this slide earlier. So if I talk through how long in my institute some of these things take, so the patient gets seen by the GP, they're seen within a rapid access chest pain clinic within about 2 weeks. It can be anywhere from 6 weeks to 12 weeks to go on to have the next test, which is often a CT. They then go back to see the cardiologist in clinic, which can take 2 to 4 weeks. If they then need to have another test, such as an MRI, that can take another 6 to 12 weeks. And then pretty quickly, you've gone from someone who presents their GP to 6 months later getting their definitive treatment. It's not quite as bad as that in a lot of cases, but that needs to change. And then the other thing is, why are people having multiple tests? Why are they seeing the cardiologist twice when maybe they just need the test? So this is how I would change chest pain pathways in the UK. So I think the patients still get seen by the GP. They get referred to a rapid access chest pain clinic. That takes about 2 weeks. In that clinic, they make a decision as to whether they get investigated at all, so whether they think there's cardiovascular disease at all. If not, no further test. And they then refer for a test, which should be a CT in 90% of cases. The 10% are people who've had previous intervention because you know they have plaque already and the benefits then are lower. And then once we do the CT, you can stratify the CT between completely normal. That person never needs to see anyone ever again. They can be discharged straight from the CT scanner. People who've got low-grade disease that need their medication optimised, but you can decide that here. You can decide at the first clinic what you'll do if the scan shows a normal CT or just mild disease, and they can go on and have that treatment without ever seeing a cardiologist again. You might want to include a nurse specialist telephoning the patient just to talk through the options. That's a nicety. But if you were being brutal with your spreadsheet, you could maybe take that out. And then finally, the patients who on CT have got significant disease that needs more specialist treatment, they then can go and see an interventional cardiologist who can plan their intervention and plan their treatment. And I think this pathway would take, if you've invested in CT and it takes 2 to 3 weeks for a CT, you can go from the patient being seen by the GP to the patient having their intervention maybe within a month to 6 weeks, which is a much better situation for the patient, and I think from a health economics it's better as well. So just in summary, I hope I've shown you that cardiac disease has a huge burden on UK health if you didn't know that already. I hope the thing that you have learned today is that cardiac CT can really revolutionise the outcome in these patient groups. We've made some improvements in infrastructure and workforce, but more needs to be built on that. And that I think if we do invest in cardiac CT and we make it a priority, the reality is we will free up funds in 5 to 10 years to deal with everything else that needs funding. So deal with cardiac CT, deal with coronary disease now. The benefits can be seen in other diseases later on. Thank you for listening. And again, thank you to Bayer for letting me share my passion with you today.
Well, thank you, Dr. Abbas. Well, I'm sold on that, so did a good job.